Hello, everyone. So we can't have class on Tuesday because of election day. So instead of holding live Zoom class, I'm just gonna record this and you guys just need to watch it before our Thursday class. And we're gonna go over the second half of the lecture. So today what I'm gonna go over is the very beginning of the lecture 9 about mentally ill offenders, and we'll cover the rest of this lecture on Thursday during class. Okay. So the first thing we have to talk about is the overrepresentation of mentally ill individuals in our criminal justice system. So data on incarceration and arrest rates have consistently shown that individuals with a psychiatric disability are overrepresented in our criminal justice system when we compare it to the general population. So it's estimated that the jail population has 2 to 3 times as many individuals with a serious mental illness than those in the general population. And just as a side note, if I say SMI, I mean a serious mental illness. So the rate of people with an SMI in our jail population has been increasing since the 1980s. When we look at the prevalence rates, the highest rate of symptoms of mental disorders is found in jail inmates. So about 60% of jail inmates have mental health disorders. About 49% of state prisoners have mental health disorders, and about 40% of federal prisoners have mental health disorders. We also have a very high proportion of inmates that have symptoms of a mental disorder, but don't actually have a history of mental disorder. So a history of a mental disorder is qualified as being told by a mental health professional, you have a mental illness, had an overnight stay in the hospital because of a mental illness, using a prescription for a mental illness prescribed by a doctor, or have had professional mental health therapy. So when we look at the percentage of people that have these problems, about 24% of state prisoners had a history of mental illnesses, about 20% of jail inmates had a history, and about 13% of federal prisoners have a history. The other thing to think about is that women are much more likely to have mental disorders when they're incarcerated compared to males. And of these, the majority of the people that have a mental illness, the majority of them are dually diagnosed, meaning they have a substance abuse problem and a mental disorder. You are going to hear the words dual diagnosis, as well as a synonym for that is comorbidity or co-occurring disorder. So those three phrases, comorbidity, co-occurring disorder, and dual diagnosis, all mean the same thing. It just means that this person has a mental disorder and a substance abuse problem. So those things often go hand in hand. There's a couple of reasons why that's the case. A lot of people will prefer to self-medicate. A lot of people with a mental disorder will prefer to self-medicate with drugs as opposed to prescriptions given by the doctor. A lot of the prescriptions given by a doctor for a mental illness have severe side effects that are really uncomfortable, like creating too much saliva is a common side effect, or being very sleepy is another side effect. So sometimes they'll just self-medicate with drugs. So the high concentration of individuals within our correctional population can be attributed to a number of things. Deinstitutionalization is probably the biggest reason, and we're going to talk about what that is in the next slide. We also just don't have enough community-based treatment for people with mental illnesses. And we're kind of seeing a shifting of the responsibility of people with mental illnesses away from community treatment in the community into the criminal justice sphere, just because there's not enough room for them in the community. So it sort of becomes the criminal justice system's problem by default. Data on incarceration rates indicate that individuals with mental illnesses serve more jail time in prison compared to those that do not. And those that do serve time really don't do their time very well. State prisoners with a mental health problem are twice as likely to be injured in a fight since they've been admitted. And jail inmates with a mental health problem they're 3 times as likely to report being physically or sexually assaulted. So they have a tough time when they're incarcerated. We also see that state prisoners with a mental health problem are twice as likely to have been homeless the year before their arrest. And if they're homeless before they're arrested, they're likely to be homeless when they're released. And we already know that individuals that don't have anywhere to go once they're released are more likely to recidivate. So it's not that surprising that individuals with a mental disorder have really high recidivism rates. About 24% of them recidivate within 12 months and 77% of them recidivate within 36 months. The other thing to think about when you're thinking about mentally ill offenders serving prison times is that the age crime curve is different for someone with a mental illness than it is for someone without a mental illness. So the age crime curve shows that peak offending for somebody without a mental illness is about between the ages of 15 to 19. If you have a mental disorder, your age crime curve, you peak around 18 to 20, which means that your first contact with law enforcement means if you have a mental disorder, it means that you're more likely to wind up in the adult system as opposed to the juvenile justice system, which is a lot more rehabilitative. So in a minute, we're going to talk about the ways to divert mentally ill offenders out of the criminal justice system. But first, I just want to point out it's never that black and white. These approaches are useful and necessary. We want to get people with mental disorders out of the criminal justice system and into treatment. However, the reality is that the way the system is set up, people with mental illnesses will likely always find themselves in a correctional setting. Even beyond that, mentally ill individuals don't wear a sign around their neck saying, "I'm mentally ill." So sometimes it's not apparent when first responders show up that this person has a mental illness. So the other problem is that the person may be stable while they're arrested and then have a mental health crisis once they're booked into the county jail. Or a lot of them, the symptoms are just go undetected. The first responders might think they're just messed up on drugs and alcohol and not realize it's a symptom of a mental illness. Or perhaps the length of their stay, the longer they're in an incarcerated setting might begin the onset of their symptoms. So now I want to talk about why we have so many mentally ill offenders in our criminal justice system. So deinstitutionalization just means when people refer to deinstitutionalization, they're talking about when our mental health facilities were shut down. A lot of our mental health facilities in the US were shut down during the 70s. So let me explain why that happened. So there was a court case, a civil court case, Wyatt versus Stickney, which is in 1972. So what happened here, Ricky Wyatt was a 15-year-old youth who was committed to an Alabama state mentally ill facility due to what his parents described as ungovernable behavior. So what happened, he was admitted and they basically just heavily medicated him to prevent him from acting out, but they didn't give him a treatment plan. So basically they just sedated him and left him in the room. At that time, the state mental facility was understaffed and little care was provided to the patients. There were just too many people being admitted and not enough staff members. So it was pretty common practice across the US during the 60s and 70s to just sedate these people and kind of leave them where they were. During this civil trial, Ricky Wyatt testified that he was sleeping on wet floors. So this was actually a class action lawsuit. And the goal here was to establish a constitutional right to mental health treatment. So basically what they were doing was setting a minimum of standards of operation for people admitted to state mental health facilities in these state hospitals. So the courts ruled in 1972 in Wyatt versus Stickney that state psychiatric houses could not warehouse mentally ill patients without offering some degree of rehabilitation, meaning you can't just lock them in a room and sedate them without actually giving them a treatment plan and providing them with individual treatment. However, at that time, Alabama was not the only state that was underfunded and understaffed and was completely unable to provide adequate treatment. So when the federal courts mandated this, all states had to make these changes. And in order to comply with this judicial directive that every patient have an individualized treatment plan, they just had to release a large number of their patients so that they had enough staff to be able to do this. So that's what we mean when we say deinstitutionalization, that most states just released like half of their patients. And then a lot of the states started closing down their mental health facilities. Because if you're looking at the budget and you see that you have 4 mental health state hospitals and they're all half full, you close 2 and consolidate. That's what we mean when we say deinstitutionalization. So the people that created these decisions, the mental health leaders, were hoping to get these people out of the mental health facilities and have them seek treatment in the community. However, the problem is that they seem to overestimate the number of families that were willing to take in and to take care of their mentally ill family members. So basically what you have is an influx of mentally ill people in the community, and there's nowhere for them to go because the families didn't want to take them in. And then if they tried to put them back in the hospital, a lot of the hospitals had closed down to save money. So there was a decrease of about 70% of state and county psychiatric beds between 1972 and 1990. The states closed about 58 psychiatric hospitals, resulting in longer wait lists for hospital admission and continued overcrowding. So like I said, unfortunately, the resulting effect of deinstitutionalization was flooding the community with mentally ill offenders. So the local community mental health resources were designed for a small number of fairly stable individuals to just receive outpatient therapy. They weren't ready for this influx of severely disturbed patients that needed to be institutionalized. The other problem too is that the state was kind of overestimating how many of these mentally ill patients would seek treatment themselves. A lot of them did not want to seek treatment, didn't think that they needed treatment. So they were just kind of out on the streets. Their families didn't want them, and they weren't seeking treatment. They weren't getting help for their mental illness. So as a result, then this large number of mentally ill individuals increased in the community, and their unconventional behavior became got the attention of law enforcement, and a lot of them wound up in the criminal justice system because there was nowhere for them to go. What we also see here is this is around the time that the homeless population hugely increased in the US. So in retrospect, this sort of vision of emptying the asylums and replacing them with community-based services seems oversimplified. It failed to account for the number of families that were willing to take them in, that these people actually wanted to receive treatment and would take themselves to treatment. But also it's pretty common for people with serious mental illnesses to go back and forth between the asylum and the community. So a lot of times what will happen is they'll be in the asylum, they'll get their meds straight, they'll be released, they'll be on their meds for a while. They start to feel good, so they think they don't need their meds and they go off their meds and they need to go back into the asylum to get their head straight, basically. Or a lot of times they'll go back into the community and go off their meds because of the side effects I was discussing earlier, just make them feel uncomfortable. So it's pretty common for people with serious mental illnesses to kind of go back and forth between the community and the asylum. So where we are now, we are focusing on decriminalization. So like I said, when our nation closed down a lot of these mental health facilities in the 70s, they didn't ramp up community treatment. And then when we realized this was a problem, we didn't open back up these mental health facilities, and it kind of became the problem of the criminal justice system. So what we're trying to do now is enter this era of decriminalization, which basically means the criminal justice system is attempting to focus more on the treatment aspect instead of the punitive nature. So it shouldn't be illegal to be crazy. They don't need to be punished. They need treatment for their illness. This idea is premised on the idea that when they have gaps in their treatment, that's when they wind up in the criminal justice system. So we're trying to use the sort of coercion of the criminal justice system to force them into treatment instead of punishing them when they get arrested for loitering or stealing because they don't have anywhere to go, or, you know, yelling at people on the street because they're hearing voices in their heads. So the last thing I'm going to talk about on here is one of the ways that we can kind of divert them out of the criminal justice system. So using a court-based intervention using mental health courts. So just like the other courts we talked about drug court, veterans treatment court, prostitution court, we also have mental health courts. So if a mentally ill person is not diverted out of the criminal justice system right away, meaning the police officers don't take them straight to a mental health facility, if they're detained by the police due to criminal behavior, then the courts get involved. So judges are then faced with a decision of how best to balance the needs of this person with a mental illness with the needs of the community. So recently, mental health courts have been popping up, and it was a common view kind of that the traditional courts weren't effective in dealing with people with mental illnesses because they were sort of the same idea with drug offenses. They were spinning through the revolving door of the criminal justice system. We were putting them in an incarcerated setting. They weren't getting treatment. We were releasing them. They would go off their meds, or they never went back on their meds. They'd commit another crime. They'd wind up back in the criminal justice system. So we're trying to use mental health courts to solve that problem. So just like the drug courts, the mental health courts authority stems from the linkages of clients with the appropriate treatment services. And the central focus of these programs is to offer supervised mental health services in lieu of prosecution and incarceration. So just like the other courts, there are differences at the county level about how these are implemented. They can be offered at pre-booking or post-booking. So you can offer them before you even book them into the jail. You can offer them after you book them into the jail. If it's a post-booking, you can offer it to, the person might have to plead guilty first, or you can withhold their adjudication and have them go through this court. If they go well, then they drop the charges. So all just like the same differences we saw with the drug courts, they exist with the mental health courts. But basically the way this works is they do an intake screening to find out what's the deal with you. And those that meet the criteria of having a significant mental health disorder can be offered this diversion into mental health court. Then they are referred to community mental health facilities for treatment and follow-up planning. And similar to all the other courts, they have to abide by the conditions of seeking the treatment that meets their needs. They have, meetings with judges either on a weekly, a monthly, or quarterly basis. And once they can satisfactorily complete these conditions, usually criminal charges are dropped or they have the opportunity to have them expunged. So the first mental health court was established in 1997, and by 2006, there were over 100 nationwide. Like I said, these courts vary across jurisdictions, but the common characteristics are this specialized court docket just to deal with mentally ill offenders, screening for acceptable candidates. They have to voluntarily enroll in the program, linking them with services in the community, and making sure that that we have supervised compliance by the court. So the judges are checking up on them to make sure they're going to treatment. So there was a survey that looked at the mental health courts across the nation. They looked at about 196 of them across the nation. The majority of them accepted misdemeanor cases, and about 74% of them would accept felony cases. Only about 20% of the courts across the nation allowed for violent felonies, and only 1% allowed cases involving significant violence. So if you are a mentally ill offender with a serious violent history, or were arrested for a violent crime, chances are you're not going to get into this mental health court. So there's a lot of variability in the eligibility criteria to be involved when we're talking about your clinical symptoms. About 43% will accept anyone with a diagnosis that corresponds with their state's definition of a serious mental illness. About a third of the remaining courts will accept people with personality disorders or or those that are mentally challenged. And a big problem here is that a lot of courts, about 64% of them, will exclude people with a mental illness if they consider, if this person also has a substance abuse problem, and they consider substance abuse to be the primary disorder, which is really hard to tell which is the bigger problem. It's kind of, and also, which came first, the chicken or the egg. And we know that people with mental illnesses are likely to have a substance abuse problem as well. So this exclusion of people with substance abuses makes these courts it makes them exclude a population of people that probably really needs their help. So also substance abusers can often be sent to drug court, but sometimes, so what may happen is this person may have a co-occurring disorder, right? So they have a substance abuse problem and a mental illness. We'll try to get them into a mental health court. They will say, no, this person has a substance abuse problem, send them to drug court. Drug court will look at them and say, no, this person has a mental illness, send them to mental health court, and then nobody takes them. So this is a surprising finding that these courts are having these problems, but it makes sense. They don't have a lot of room for everybody, so they're trying to choose the people that fit the criteria the best. But this is a significant problem in these courts, is that you're kind of sending these people back and forth. So perhaps what we need is a court for co-occurring disorders, since it is so common. All right, so that's all I wanted to cover in this lecture. Please make sure that you watch this before our class on Thursday. And on Thursday, we'll pick up right here and talk about interventions that are available if you get booked into the jail and you can't you can't get into a mental health court. So if you have any questions about this lecture, please send me an email. I'm happy to clarify. If not, I will see you guys on Thursday.